Thank you for joining me for my talk about infectious complications in patients on peritoneal dialysis. My name is Stan Fan and I work at Barts Health. To start, I wanted to talk about how we start someone on peritoneal dialysis, just to describe the things that we do to try and minimize infections. So the actual case doesn't matter so much, but the case I've picked on today is a lady who's 63 years old, hypertensive nephrosclerosis, and in our low clearance clinic she was seen, has a declining GFR, and it was decided with her that she would prefer to have a home-based treatment, peritoneal dialysis, and in particular because she didn't think she would be able to cope with the machine and the family were busy, we decided to go for assisted APD. And at a certain point, we arranged for the PD catheter to be inserted. She had no previous abdominal scars, so we planned for this to be done what we call a medical PD catheter or by Seldinger technique. At this point, before I describe actually what we do, I just thought it might be useful if you stop this slideshow and just think to yourself, what do you do in your unit? And actually, more importantly, what do you think we should be doing in the ideal world to minimize risk of infections in our patients, both peritonitis and particularly exit site infections? What should we do leading up to the PD catheter insertion? What should we do on the day of the PD catheter insertion? And what should we do in the weeks after PD catheter insertion? I hope you've had a chance to think what you feel should be the ideal pathway for the patient as they have a PD catheter insertion. So I'll describe what we do, and bear in mind that this is pre-COVID, so we now have a whole load of COVID swab screening. But what we've done before is about a week before their planned PD catheter insertion, they come to the clinic, pre-admission clerking, have blood tests done, and we do a triple swab to screen them for MRSA, not MSSA, but just MRSA. We give them at the same time, without knowing the results, their decontamination body wash and Naseptin for their nose, and we also give them laxatives and ask them to start taking that 2 to 3 days before their PD catheter insertion. It's an interesting point as to why we just screen for MRSA and not MSSA or Pseudomonas for that matter. I suppose it's tradition and also workload. You could argue that maybe we should be screening for other important pathogens, as that will give us an idea on their future risk for infections. On the day of the procedure, it is important to consider prophylactic antibiotics for them. That is highly recommended by ISPD guidelines. In our case, we give them vancomycin and gentamicin, and that depends on your unit policy. Some may argue the gentamicin is unnecessary. But apart from giving antibiotics, the two other things that really do help minimize future infections, especially exit site infection, is if you plan carefully where the exit site is. So it has to be somewhere that the patient can see to do the exit site, and it has to be somewhere where there's no trauma, for example a belt line. Creating the exit site has to be done carefully. You don't want the exit site incision to be too large. If it is, then there's a tendency to put a suture in, which we definitely don't want, because foreign bodies encourages colonization of the exit site, which is undesirable. What do we do immediately after the operation? Well, we put a dressing on. we would always use a non-bioclusive dressing, and we do that because this dressing has to be undisturbed for 1 week. Now this is quite different from a standard surgical dressing. So normally a surgical wound is closed, primary closure, you get primary healing, you have a dressing which is often bioclusive to stop bacteria getting onto the wound while it heals, but the dressing is changed very frequently. For us, we do not want to change the dressing for 1 week. We do not have primary healing. We have a big hole in the skin, and so the healing has to occur by secondary intention. So we don't want the exit site to be opened, we don't want it to be traumatized, we want it to heal by itself. That means that for the first week, the patient has to be told no showers, no baths. That dressing should not get wet. 1 week after the catheter is inserted, we would teach the patient or the family to do the exit site care. Now this is before perhaps when they come up for their PD training. And we do this because in the past we used to bring patients up once a week for us to do the exercise, and then we do their exit site training during their PD training. But that would mean they can't have a shower or bath for 2 to 3 weeks, which for many patients, especially if it's hot summer, is unacceptable. So 1 week afterwards, the patient is taught how to do the exit site, and our protocol is to use mupirocin ointment for the exit site. I hope I haven't forgotten anything. Or rather, if you do think that our pathway, our care can be improved, then please do email me. I'll be very interested to hear. Always happy to learn and get new ideas. So sorry to labour such a simple case for so long, but it really just highlights all the things that we should be thinking about to try and reduce exit site infections. We know that peritonitis is probably one of the greatest reasons why we lose patients on PD, and so exit site is often sort of the Cinderella of infections, but we shouldn't underestimate how important it is. Well, how do we diagnose exit site infections? Well, usually when you see something that's infected, you just know it is. But there is a good scoring system which is published in the ISPD guidelines, which you can use. It's particularly important if you want to track an infection to see if it's getting better or worse. But in terms of diagnosis, essentially, if there is pus coming out of an exit site, it's infected. The corollary is that if you don't think it's infected, you don't need to swab it. We know that exit sites can be colonized. Colonization doesn't need treatment. So don't take a swab unless you think it's infected. If you do think there is an exit site infection, do consciously consider whether or not there is a coexisting tunnel infection, because that's a very bad prognostic sign. You can do things such as create a new tunnel or give prolonged antibiotics, but unfortunately prognosis is poor, so you have to be aware that this person has poor prognosis. So I've described what we do for exit site care, but what's the evidence? Well, if you want the evidence, then I refer you to the ISPD guidelines, which I've mentioned in the past, written by experts, and I hope that what I've told you is based essentially on what is written down in these guidelines, and also a little bit of common sense as well. As you'd expect, if you're trying to devise a program to reduce infection rates, then training the patients on how to do their exit site and how to do their dialysis is critical. It's often done by the nurses, so I'm not going to labour the point or expand on it any further, but other than to say that if you're interested, I think this is an important area for research and exploring. But in terms of what we do as physicians, well, I've mentioned that we use mupirocin ointment applied to the excess site. It doesn't have to be mupirocin. I know many units use gentamicin, but some sort of antibiotic ointment is recommended by ISPD and actually gets a 1A recommendation. However, there is no cleansing unit that's shown to be superior, and it's interesting that we've gone through the whole gamut of this. We've used alcohol wipes when I was first made a consultant here. For a short while we changed over to chlorhexidine or a newer version of chlorhexidine. We didn't find that improved matters any further. We're going with saline, although now there's this trend that we're using and asking the patient just to clean and wash the excess site carefully when they're having their shower with the dressing off, and then clean it with saline before they apply their new dressing. So there's no particular definite way of doing an excess site care, as long as it's done carefully without traumatizing the excess site, and then applying some form of antibiotic cream. What do we do if someone has an infection? Well, of course you have to treat it with antibiotics. What antibiotics will depend on your local unit and your microbiology advice. The only thing I would like to add is that if you use mupirocin on the excess site, we have found that the proportion of infection caused by Pseudomonas compared to, let's say, Staph aureus is much higher. So choose your empiric antibiotic if you use mupirocin to definitely include some pseudomonal cover. You don't want to go 3-4 days and then find you've given an antibiotic which is ineffective. 1C guideline recommendation is that during an infection the excess site should be cleaned daily, and there is obviously some sort of logic to that. I've already mentioned tunnel infection is bad news, so is Pseudomonas infection. So they need at least 3 weeks of antibiotics and much more care in following them up. Okay, you'll be pleased to know that I'm going to stop talking about excess sites and I'll talk about peritonitis. Now, when I was a registrar, I used to get very confused about what's a relapse, recurrence, reinfection. I don't think it really matters, except for there are definitions of these things which you do need to know about. So what does this person have? This is a person who started APD, let's say, 1st of January 2015. And then when you see him at the end of that year, he's had 2 episodes of peritonitis. The first one was on the 1st of November. Staph epi, fully sensitive, given 2 weeks of antibiotics. For us, our antibiotic treatment for Staph epi is IP vancomycin and oral rifampicin, unless there's a contraindication to rifampicin. Having had that, there was initial good response, but he came back on the 10th of December with another episode of peritonitis, growing Staph epi again. So, does this man, the second episode on the 10th of December, do we call that a recurrent infection, a relapse, a repeat infection, or a refractory infection? Okay, I'll just give you a minute to think about it. And here's the definitions of the different terms. So recurrent is if the infection is within 4 weeks of the previous one. That's 4 weeks of stopping the antibiotic. So in this case, the clock starts ticking on the 15th of November. So if it's within 4 weeks and it's a different organism. A relapse is if it's within 4 weeks with the same organism. So that's the case. Same organism within 4 weeks. So this man actually has a relapse of his peritonitis. If you want to know what the definition of repeat is, well, it's if it's the same organism but more than 4 weeks, and refractory is self-evident. That's if it's not responding to treatment. Good, so let's have another case. Actually, this case is someone who perhaps we haven't really covered ourselves in glory at Bart's Health. But let me explain or talk you through this. So it's a gentleman who started APD in June 2016. It was mostly performed by his wife and daughter. They were trained to do the APD for him, although he was perfectly capable and he did occasionally connect and disconnect himself. However, he generally found that he wanted the family to help him do the dialysis for him. So he got started on APD. We thought he was doing well, but unfortunately a few months later he came back with peritonitis. It grew staph epi. I've already explained that our antibiotic protocol would treat this with IP vancomycin and oral rifampicin, which you received 2 weeks worth. After an episode, we always try to do a root cause analysis. So the patient had a home visit. Since most of the dialysis was being done by the wife and the daughter, they had a technique review. They were felt to be perfectly good at doing the exchanges and setting up the machine. The home situation looked good. Where they were doing the connection wasn't particularly overcrowded. So we thought, well, this was a one-off. People are allowed to have one episode of peritonitis. Let's hope he doesn't get any more. Unfortunately, a few months later, he came back again with staph epi peritonitis. So this is more than 4 weeks, same organism. So by the ISPD terminology, I suppose this would be a repeat episode of peritonitis. We did the same thing again. We tried to do root cause analysis. We went on another home visit. The daughter and the wife was again reviewed. We couldn't find any particular issues that was missed on the previous visits. So we hoped again that maybe this was another one-off, because otherwise he was doing extremely well on PD. He was well rehabilitated, he was getting about, we had activated him on the transplant waiting list, and for those who go for small solute clearances, he was clearly getting good dialysis with a total KTOV measured at 2.3. So we kept our fingers crossed, progressed, but unfortunately he came back. Another episode in May 2017, again staph epi, and then a month later, in other words within 4 weeks of finishing the antibiotics, he had another episode. So this one now is a relapse, culture negative, and I suppose at this point the penny dropped. I mean, this gentleman has had 3 de novo episodes of peritonitis in 12 months, so he has a peritonitis rate of 1 in 4. Bear in mind that my unit has a peritonitis rate generally about 1 in 32, sometimes 1 in 36, so this man alone is destroying my peritonitis rate. So he was flagged, and clearly we needed to do something different. We just can't carry on going on like this, even if he seems to respond each time we give him antibiotics. So in retrospect, what could we have done differently? What should we have done differently? So I suppose point one is we documented that we reviewed his home technique. I suppose we should have documented much more explicitly whether or not he had a tunnel infection, which is why he's getting these recurrent episodes of peritonitis. And if we weren't clear if he had an exit site and a tunnel, then we could have arranged for an ultrasound to look at the tracts and particularly at the cuffs to see if there's any swelling or edema around the cuffs to suggest a tunnel infection. But equally, I suppose the real question is, how many, after just 2 episodes within 6 months of starting PD, would exchange a PD catheter at this point and say, well, he's had 2 episodes, the PD catheter is probably colonized, which is why he's had it again. If we had exchanged at this point, could we have saved him these 2 episodes of peritonitis? I must say, I did think about that. I think it's harsh, personally, although my views are beginning to change a little bit. But back in 2016, I was rather reluctant to refer people for PD catheter exchanges when they're doing so well and the PD catheter is working so well. So actually, I didn't do nothing at this point in December. I did say he is at high risk to have another episode, and if he did, then he would have to have his PD catheter probably removed, although I take the point that it could be exchanged. But if it was removed, he would have to then go for hemodialysis via a tunneled hemodialysis catheter. So actually, I don't know if it's the right thing or the wrong thing, but what I did is I referred him for a backup fistula in the hope that he would have a functioning fistula if he had if and when he has another episode of peritonitis. And at that point, if I could remove his PD catheter, he could transition smoothly to hemodialysis via a fistula whilst waiting to decide whether he wants to come back to PD. So in fact, he had the referral in January, he had his surgery in February. Unfortunately, there was primary failure, which is why we're now in this position that he hasn't got a backup fistula, and clearly we need to do something about his PD catheter. So at this point, do we exchange or remove, rest, and then if he wants to come back, reinsert? What we did was to remove the PD catheter because it was quite a high white cell count. It wasn't responding to the antibiotics quite as quickly as we would like. So we removed his PD catheter, rested him before reconsidering whether to put a PD catheter in, although I accept many places would successfully have a PD catheter exchange. What is a good peritonitis rate? So this is an old publication, so the data is more than 10 years old, but I think we can still look at it and just have a think. So United Kingdom, we're in the middle of that table, and we're about 0.7 episodes per year. You'll notice that I'm now talking in terms of episodes per year rather than one in how many patient months. This is the new currency, so to speak, recommended by ISPD. But 0.7 represents about 1 in 18, and that's what the average we were doing in the UK 10 years ago. But if you look at it, even if we improve, and now I think the average is about 1 in 24, that's still, maybe we can be improved upon. Look at Japan, look at Austria, even United States, which we always think of as a backwater for PD. They're achieving peritonitis rates of 0.2 to 0.3. In other words, 1 in 50, 1 in 55. So vastly better than what we're achieving in the UK. So how can we improve? Well, we can improve by looking at our training program. I've already said training is probably the most important thing to try and reduce touch contamination and therefore reduce peritonitis rates. So how do we train? Well, we ask our nurses to devise a training scheme, quite rightly, and our nurses deliver it very well. But does that mean we don't have a role and input at all? I think we do, because I think not all the nurses will have read all the guidelines. I hope we do. We should have read this guideline, and perhaps as part of our continuous quality improvement programs, we can suggest to the nurses, are there anything in these guidelines that we would like to adopt for next year? And once we've adopted it, we can do an audit to see if that has improved. Hopefully it has a little bit. And then rather than sit back on our laurels, say, okay, good, we've improved a little bit. What's the next recommendation that we can introduce for next year or the year after? So what have we done at BART? So what are the plans or innovation, so to speak, coming from the ISPD guidelines that I'm hoping to incorporate into our training programs. So here's just a few. I've picked these, but you can easily go into these guidelines and choose 3 or 4 different topics, and that's fine, as long as we keep trying to have a CQI program running. So the old Renal Association guidelines recommended one-to-one training. We're moving more towards group training. The way I look at how schools work, yes, one-to-one tutorials are great, but actually there is also something to be said about classroom teaching and how students interact with each other and help each other to learn. We always acknowledge in terms of medical care that every patient is different, and we adapt our treatments, we individualize our treatments. Do we adapt and individualize the training program for a patient? Because different patients prefer different styles to learn. Some people prefer to be spoken to, some people prefer something visual, some people prefer something much more practical. For this talk, I'm afraid you're just getting one way that you're going to learn, and that's hearing me rattle on. And I suspect, to a degree, that's what happens with our PD training. There is just one training program, which is tweaked a little bit here and there, but essentially there's just one way of teaching, and that depends on what the nurse or the teacher is comfortable with. But it should be the other way around. We should have different training programs which we roll out depending on what the patient prefers. And then the third thing which I really want to try and emphasize within my program, certainly, and I'll report back in a few years whether it is helpful or not helpful, is try and build in muscle memory during the training program. So there's a suggestion that maybe we should be teaching the patient, getting the patients to do their exchanges, and they should be able to perform their exchanges without errors at least 3 times before they are so-called passed and allowed to go off and do their dialysis by themselves at home at night. Again, I want to emphasize that I've just picked a few recommendations or a few ideas from these guidelines. What you decide to try and introduce in your unit can be different, as long as we continuously try something and try and improve year on year. What else can we do to try and prevent infections? So I've already talked about the PD catheter insertions and exit site care. I suppose people always ask about biocompatible solutions. Do they reduce your risk of PD peritonitis? Well, the ISPD has no specific recommendation based on biocompatible solutions, although there is this large randomized controlled trial conducted in Australia, New Zealand, and actually I think that in Singapore and some of the other South Asian countries, where they randomized people to balance, which is a biocompatible solution, and the standard solution, Stay Safe, and they did see a difference in peritonitis rates. Now, this wasn't their primary objective of the study, a secondary objective, but it does show some difference. This difference, however, hasn't been seen in a lot of other studies, and that's why, and given the cost differential, I suspect that's why the ISPD won't make any specific recommendation, although it's intriguing and it does support perhaps the use of more biocompatible solutions. I talked about what we do when someone gets an episode of peritonitis. It's important that we do root cause analysis, and as part of that, I always go through their medical history. When I see them, I always ask them, have they had investigations or tests that we didn't know about? So have they had a colonoscopy, for example, or a gynecological investigation? Because we know that there may be translocation, especially if you're doing a colonoscopy, a translocation of bacteria into the peritoneum. And the recommendation is that if you are going for these invasive tests, you should have prophylactic antibiotics. So how good is our systems in picking up patients who are now planned for different investigations? In the past, it all came through a unified system, but now care is a little bit more fragmented. There are bowel screening programs, so the patient may be called up for bowel screening without really us knowing about it. I described how we do home visits after every peritonitis and other modifiable risk factors. I'm not saying that these factors are necessarily causative of the peritonitis, but certainly there's strong association. So hypokalemia is associated with increased risks or increased rates of PD peritonitis. Whether correcting the potassium actually improves the rate or whether hypokalemia is just an indicator of comorbidity is less clear, but certainly correcting hypokalemia is something that perhaps we should be more aggressive towards. Treating constipation, although I'm against the very strong stimulant laxatives, but I'm definitely in favour of screening for and trying to support patients who may be depressed or may be lacking in motivation, because actually these are the two factors which carry the highest risk. I'm not entirely sure how we support patients on PD, but clearly this is an area of further research, and if we can, I think this is where peritonitis rate will be improved the most. Okay, so my last case, and I'm sorry I've rattled on a little bit longer than I expected, but the final case is a gentleman who presented in 2014. We don't really know the cause of renal failure, and I suppose it's not really relevant in this case, other than to say that he wasn't immunosuppressed. He was referred for transplant and dialysis counselling, and he chose to have PD, so PD catheter was put in. He was started on what we gave routinely at the time. Our initial APD program is 8 hours, 4 cycles, 2 litre fill volumes with 75% tidal. Unfortunately, he had continuous alarms at night from the APD machine. He had constant drainage issues. But over time he persisted with APD, and over time things got a little better, although we needed to increase his dialysis, and he was on 9 hours, 4 cycles, 2.2 litre fill, 80% tidal with a last fill of 2 litre extraneal after 1 year of dialysis. He was otherwise doing very well. He was activated on the transplant waiting list, and for the first 2.5 years he had no exit site infections, no peritonitis. But then he came up complaining of vague abdominal pains, night sweats. He attended the clinic, bringing up his overnight PD effluent sample from a PET test, and it was described by the nurses as misty, and there were 75 white cell counts, 45% of them neutrophils. The gram stain was negative. So the first question is, does this person have PD peritonitis? So what is the definition of PD peritonitis? What is the diagnostic criteria, I mean? Well, ISPD says if you have 2 or more of these factors, so white count of over 100, well, he didn't, although you have to bear in mind that this has to be after a dwell time of at least 2 hours. Now, this was an overnight sample, so that's fine, but if someone has got brings up a APD sample from the drain bag, you know the dwell times there is usually less than 2 hours, so they may have peritonitis even if the white cell count is less than 100 in those cases. The neutrophil count should be greater than 50%. In our case, it's less than 50%, and there should be positive culture. In our case, the gram stain was negative, and I'll tell you now, the culture was negative. So by ISPD guidelines, this person did not have PD peritonitis. So then you have to think of what other causes are there of cloudy bags. So just because you have a misty, cloudy bag Yes, 99.9% of them is going to be from an infective cause, but there are other causes. Now, I must admit, a lot of them are incredibly rare. Chylus, malignancy, eosinophilia with allergic reactions. But it's something just for you to bear in mind. So this man, we went through it and we wondered whether, in fact, it was a viral infection because of his temperature. His lipase was normal, and you should ask yourself, why do I say lipase and not amylase? And the answer, of course, is because he's using icodextrin. So icodextrin interferes with amylase assays. So if you want to diagnose pancreatitis, please use lipase and not amylase. Well, the other thing about the night sweats, of course, is yes, that suggests maybe infections, but it also raises the possibility of maybe lymphoma, but he's not been transplanted, he's not been immunosuppressed, so less likely to be, for example, post-transplant lymphoproliferative disease. But he's of Asian origin, so we were wondering about TB as well. So we did a CT scan and that was normal, and we couldn't find any lymph nodes to biopsy. However, we did send off PD effluent for PCR, and a little bit to our surprise, it came back positive. They found DNA, TB DNA in the PD effluent. The cultures were negative. So we were quite taken by the use of PCR, and I suppose in COVID days, this technology has really moved on leaps and bounds. But although this was a positive case in favour of PCR, there is insufficient evidence at the moment to support the use of this novel technique for routine diagnosis of PD peritonitis. However, in isolated cases, it's something for you to think about using. We felt it was clinically significant given his racial origin, and so we actually started to treat him. Very debatable, and I know there are strong views amongst the audience and amongst the faculty members about whether or not someone with PD peritonitis should have their PD catheter removed, or whether we can treat PD peritonitis whilst they're on PD. We actually, because he was doing so well on PD, we actually treated him without removing the PD catheter. And actually, now for the last case, I just wanted to present a case to talk about treatment options. You'll notice the last case was really about the diagnosis of PD peritonitis and what we can do to try and improve the culture, trying to identify the organism causing an infective PD peritonitis. But this is much more about treatment. So this was a lady who started PD about 4 months ago, and then she presented quite clearly with peritonitis, severe abdominal pain. There was evidence of a septic shock. She was relatively hypotensive for what she normally is. She was pyrexial. She had peritonism, and when we drained out the PD fluid was what we would call pea soup. In fact, we couldn't get a white count. The microbiology MLSO said the PD fluid was just too viscous to count, although any cells she could see, they were all neutrophils. And even on microscopy, she could see gram-negative rods. Blood tests were unremarkable, other than to say it's a real shame she developed this peritonitis because she was doing extremely well in these 4 months. She was very well rehabilitated, and you can see from her results that she was very well dialyzed. So, treatment. Well, I suppose we always think about antibiotics first and foremost, and that's quite correct. But don't forget about some form of analgesia as well. And when you have someone with really severe peritonitis, do consider doing flushes. Now, when you flush, you will delay the IP antibiotics. Okay, so it's not something that we do for every case, but in patients with severe peritonism, it really does help. So in her case, we did do, well, usually, or in the old days, we used to do 3, but in her case, we did 2, and then we gave empiric antibiotics. Our empiric antibiotics is vancomycin, gentamicin, and ceftazidime. I'm sure most in the audience will think that this is an overkill. I regularly have arguments as to why I think my empiric antibiotics works, and we can discuss this at a later date if you want. But anyway, that is what we gave. But because of the severity of the peritonism, you also have to consider whether or not there's a surgical pathology. So a CT scan was requested, although by the time she had it, it was the next day. Interestingly, the CT scan was pretty unremarkable. No obvious bowel perforation. However, the culture already came back showing 4 different organisms. So that really does suggest, even though you can't see it on the CT scan, there must have been some sort of perforation, and one assumes it's a small diverticula that perforated. Now, normally we would just remove the PD catheter. There's no doubt. It's better to remove a PD catheter, let the patient recover, and then if they really want to come back to PD, of course we can reinsert. We were planning to do this, but she was really insistent that she did not want to give up PD. So even though she had this severe pain the previous day, she wanted to see if there was any alternative to moving to hemodialysis. So, somewhat against our better judgment, I suppose, we acquiesced, and we decided that we would stop the vancomycin and make sure we add in some sort of anaerobe cover as well as gram-negative cover for gram-negative rods. The other thing which we did is add in fluconazole. Now, this is controversial, but you should be aware that ISPD guideline 1B is that for at any point you give antibiotics to our PD patients, you should give some form of antifungal prophylaxis. Now, we very rarely do that in UK. It's not standard practice in our unit, but that is against the recommendations of ISPD. But in this case, because we think she had a perfed diverticulum, and we also rationalised the antibiotics slightly so that she had meropenem providing good gram-negative cover as well as anaerobe cover, and we continued gentamicin with the oral fluconazole. And actually, the very next day, her PD fluid was almost completely clear. The white cell count had fallen to just 110. By day 7, her PD fluid was clear, white count was completely normal, and we could plan sending her home. Now, bear in mind, she was on IV meropenem. I suppose the option, of course, is that we could change it to IP to make it easier. So she can have IP meropenem and gentamicin and oral fluconazole. But if you do this, be aware that meropenem and gentamicin cannot mix in the same PD bag. In fact, meropenem and vancomycin cannot mix either. So in her case, she had to give the meropenem in a different bag to the gentamicin. Now, she was on APD, so we could give one, for example, the meropenem in her last fill, but then she would have to do a manual exchange at some point in the day to get the gentamicin in. Or the alternative is to send her home on IV meropenem. So I suppose this is an unusual case, and it's really to highlight a few things. First of all, is to highlight the ISPD guidelines of antifungal prophylaxis if you want to follow it. And the second thing is, do remember that not all antibiotics can be mixed. So I gave you an example here where the antibiotics can't even be mixed in the same bag, but there are other examples where the antibiotics can't be mixed in the same syringe, but you can draw them up in different syringes and inject them into the same bag. So for example, vancomycin and ceftazidime, you can't mix them in the same syringe, but they're okay if you inject them into a 5 litre or a 2 litre bag. Now there are good publications telling you what antibiotics can go into what bag and their stability and their mixing. So if you're using anything slightly unusual, do refer to them. But I would recommend that we take microbiology advice. So they often do advise different antibiotics based on their sensitivities, and when you follow them, do double check about the pharmacokinetics and pharmacodynamics and interactions. So you'll be glad to know that that's the end of all my cases. And as with all talks, it's traditional to come up with some sort of conclusions. Well, I really struggled. What sort of conclusions can I give you? Because all I've done is describe a few cases which I thought show some teaching points. So my conclusion really is, if you want to learn about PD peritonitis, it's not to sit here and listen to me whittle on, but actually go online and read the ISPD guidelines. Here are 3 guidelines which really cover in depth everything which I've talked about and more. If you do want to think, what did I cover in my cases? We talked about the different diagnostic criteria for exit site infections and peritonitis, what things we can do to try and minimize risks of exit site infections, and for that matter, peritonitis. Training, but do think of other modifiable risk factors, situations at home, what social factors, what medical interventions our patients are having without our knowledge. And when we come to talk about treatment, think about the pharmacokinetics and the pharmacodynamics of antibiotics. I've not actually talked, there was another case which I was hoping to present, and maybe another time I'll present about this. But you can try different novel antibiotics as long as you go back to the basics of knowing what you can mix and the pharmacokinetics of these. But probably most important, if you want to really help our patients and improve the PD program, is just to make sure that every year you have some sort of continuous quality improvement program going, focused on reducing infection rate. And I ask you, do you know what yours is in your unit? When was your last CQI focused on infections in your unit? And shouldn't we always have one ongoing? And on that note, I'd like to thank you for your patience and for sitting there listening to me talk about PD. Thank you.